Hello, this is Peter Soukas from Brown Medical School in Providence at the Miriam Hospital. I'm going to be talking about access site selection to treat aortoiliac disease. I have no disclosures directly related to this presentation. Well, if we're talking about access, we need to talk about best practices, and that usually includes preoperative imaging, which can be very helpful for case planning, but also includes using ultrasound-guided access with a micropuncture kit. We do this routinely on all of our cases unless we've decided to go a priori directly to radial artery access. Radial access for iliac PVI is becoming more popular because of the lower vascular complications associated with the radial artery approach, avoiding diseased, obese groins, earlier ambulation, shorter length of stay. But we have to acknowledge that there are limitations due to spasm and tortuosity of the radial artery. And right now, we still have somewhat limited equipment lengths and treatment options available. It's important when considering peripheral intervention from a radial approach to know your distances to make sure that your equipment will be long enough to reach the desired target stenosis. This has been improved dramatically in the last couple of years now with the availability of the RTP Terumo sheaths and balloons. This is an example of a left iliac occlusion from in-stent restenosis that was approached from the radial artery. Initially, a 300 centimeter supercore wire was used to deliver a 6 French shuttle sheath to the distal abdominal aorta, crossed with a stiff glide wire, and then balloon angioplasty with an 8 millimeter balloon with an excellent angiographic result. Our next case is a female smoker with severe right leg claudication. She was subsequently found on angiography to have an occlusion of her right common iliac artery. So in this particular case, a variety of potential approaches, retrograde from the right, left up and over, or coming from above. We initially tried a retrograde access, but unfortunately resulted in a wire going into a subintimal position. Tried from a left up and over approach, but again, because it was such a short cap, we just didn't have enough ability to penetrate that cap, even with the reverse curve catheter. So in this particular case, simply switched to an antegrade approach from a left brachial artery. We're able to traverse that occlusion very nicely, exteriorize that wire with a quick capture device, and then proceed to balloon angioplasty and kissing stents to the common iliacs with self-expanding stents to the external iliacs with a very nice final angiographic result. Our next patient is a 68-year-old morbidly obese gentleman with severe claudication of the left leg secondary to an EIA occlusion with 2 prior unsuccessful attempts to cross. His initial angiogram showed no significant disease of his infrainguinal vessels, but you can see his long EIA occlusion. So in this particular case, we did secure a 4 French sheath in a retrograde fashion on the left, but we're able to deliver a soft glide wire and a support catheter into the hypogastric, then switched out for a stiff glide wire to deliver a French sheath up and over the horn. That then allowed us to deliver a 14S crosser, fortunately, through the true lumen of the occlusion into the SFA. This was then followed by balloon angioplasty and stenting with a very nice angiographic result. Our next case is a female smoker referred for severe right calf claudication that had progressed more proximally in the leg. Her initial angiogram shows a complete occlusion of the external iliac artery with reconstitution at the level of the inferior gastric artery. She had no significant infrainguinal disease, and so the question is, how would you approach this? Because there was no really good beak for antegrade access, we specifically accessed the right common femoral artery in an retrograde fashion, placing the wire in the deep iliac circumflex branch to give us a little bit more purchase so that we could anchor a short sheath in the common femoral. We're then able to cross that from the retrograde approach with a 14S crosser. Once we confirmed we're in the true lumen, proceeded with balloon angioplasty and self-expanding stents with a very nice angiographic result. Our next case is a 71-year-old woman who had critical ICA disease and was referred for consideration of staged carotid artery stenting, but because of her severe claudication, which was more lifestyle limiting, this was addressed first. You can see that initial access on the right, there is an occlusion of the common iliac artery. subintimal passage was noted with attempted retrograde traversal with the wire. In this particular case, decided to go ahead and take our medicine, obtained left retrograde access. There was a nice stump there in the origin of that common iliac artery, and that allowed us to traverse that occlusion antegrade with the glide wire. That wire was then successfully snared and exteriorized, and then once that wire was delivered into the true lumen of the aorta, we're able to proceed with stenting with both balloon expandable and self-expanding stents. Very nice angiographic result with complete resolution of the symptoms. Our next case is a 56-year-old obese female with progressive aortic stenosis who'd had prior back surgery ×3 with severe claudication. She was felt by her vascular surgeon to be at high risk for open repair. She underwent angiography at her local hospital in February. At that time, angiography was obtained from right common femoral access, and she was noted to have a left common iliac occlusion with a right common iliac artery stenosis. Unfortunately, the operator was unable to cross the CTO on the left, and the procedure was aborted. Because of our availability of having intravascular lithotripsy at our institution, she was graciously referred for another attempt at peripheral intervention, which unfortunately was delayed until April of this year due to the COVID-19 quarantine. We initially obtained access on the right, and unfortunately her common iliac artery stenosis had now progressed to the point of occlusion. For this reason, we obtained brachial artery access, and additional angiography with aortography showed distal occlusion of the aorta at the level of the IMA with dense calcific common iliac occlusions. In this particular case, we were able to then deliver a wire antegrade into the SFA, followed by placement of a short 4 French sheath in a retrograde access. We're able to obtain true lumen access in a retrograde fashion, then cross the right common iliac occlusion from the antegrade approach. That wire was successfully exteriorized through a 4 French diagnostic catheter, and then after obtaining bilateral access in the aorta, we proceeded with upsizing of our sheaths and predilation with 5mm balloons. Repeat angiography shows restoration of antegrade flow. We then performed intravascular ultrasound imaging for stent sizing, followed by shockwave balloons and placement of stents with an excellent angiographic result. So in summary, the location and nature of the lesion are the primary determinants of the access approach, as I've outlined here. And please feel free to contact me for any questions. Thank you.